Good morning, consultants, senior registrars and nurse officer. I'm Dr. Idahosa Faith. I'm presenting principles of management of trachoma. These are my outline. We'll start from the introduction, look at the epidemiology all through to the role of family physician in trachoma management, conclusion and references. Trachoma, trachoma is a neglected tropical disease that and the leading infectious cause of preventable blindness worldwide. It is a chronic bilateral keratoconjunctivitis. The word trachoma originates from the Greek word rough, which describes the appearance of the cornea when the disease is chronic. Infection usually first occur in childhood, but people do not become blind until adulthood. And trachoma is also referred to as a quiet disease because it progresses over years as repeated infection causes scarring on the inside of the eyelid of the eyelid. Trachoma is hyper-endemic in many of the poorest and most rural areas of 42 countries in Africa. It can occur worldwide, but it's more common in the Middle East, North Africa, Sub-Saharan Africa, and areas of the Southern Asia and China. Africa remains the most affected continent, and it is responsible for blindness or visual impairment of about 1.9 million people. In hyper-endemic areas, active disease is most common in the preschool children with prevalence rates as high as 60 to 90%. Trachoma is caused by chlamydia trachomatis. The serotype ABBAC are known to cause ocular hyperendemic trachoma. D to K causes paratrachoma, neonatal and adult inclusion conjunctivitis. The chlamydia lymphogranulomatis serotype L1 to L3 causes genital to eye trachoma. Incubation period of trachoma varies from 5 to 21 days. The predisposing factor include the age, sex, race, climate, socio-economic status, environmental status. Sources of infection are the conjunctival discharge of affected person. There's also a room for superimposed bacterial infection. Trachoma is transmitted either through direct spread, the vector transmission, or material spread. Under the material spreads, we have the 5Fs and the 6Ds. The 5Fs include the flies, feces, faces, fomite, fingers, while the Ds are dry, dusty, dirty, dung, discharge density. We can look at dis picture showing the life cycle of trachoma. Don't forget it's commoner in children and female. Yeah, from the infection infecting the eyes, flies carry the microorganism on children's eyes to feed on discharge. There's contact, women who take care of children get infected. From there it move for there's spreading out. The fly that breed in human feces spread the disease to others, and the circle keeps going on and on and on, from infection to spread to infection and spread. So for us to understand trachoma, we just take a brief look at the anatomy of the eye. The eye is The upper eyelid covers house is the front cover of the eyeball. The upper eyelid is divided. The eyelid there is what we call the conjunctiva that is covering the outer surface of the eye. The conjunctiva is divided into two parts. We have the palpebral conjunctiva and the bulbar conjunctiva. So in trachoma, this palpebral and bulbar conjunctiva, they play a role in the pathogenesis of that blindness. Also, looking at the cornea, we take note of the limbus area where the bulbar conjunctiva meets the cornea. In infection of the eye with chlamydia trachomatis, there's inflammation as a result of the infection. This inflammation leads to the infection is characterized by predominance of lymphocytes and monocytes with plasma cell and macrophage infiltrate. The intense inflammatory infiltrate leads to the formation of follicle and papillae within the conjunctiva. The recurrent conjunctival infection causes prolonged inflammation that leads to conjunctival scarring. There is also atrophy of the conjunctival epithelium, loss of Goldberg cell and replacement of vascular subepithelial stroma with thick bands of collagen. Over time, the scar formation leads to entropion and trichiasis due to the contraction and the buckling of the upper eyelid tarsal plate. Continual rubbing of and scratching of the eyelid on the cornea may now lead to what the blindness that is like the ultimate may now lead to blindness. The natural history of trachoma is characterized by the development of acute disease in the first decade of life, which continues with slow progression until the disease becomes inactive in the second decade of life. The sequels occur the sequelae of trachoma occur usually after 20 years of the disease. Thus, the peak incidence of blinding sequelae is seen in the fourth and fifth decade of life. What are the clinical features of trachoma? In the absence of secondary infection, the symptoms of trachoma are minimal and they include foreign body sensation in the eyes, occasional lacrimation, slight stickiness of the lid, scanty mucoid discharge, itching of the eyes, excessive lacrimation, and there may be pain and photophobia. The clinical features also include exudation, edema of the eyelids, and there may be redness. In the presence of secondary infection, symptoms of acute mucopurulent conjunctivitis develop. The signs that we see in trachoma are congestion of upper tarsal and bulbar conjunctiva. Then you can see follicles in the conjunctiva, papillary hypertrophy and conjunctival scarring. It's the scarring that leads to the entropion. The corneal signs are superficial keratitis, which may be present in the upper part, apert follicles, panos, corneal ulcer, apert pit and corneal opacity. Apert follicles refer to the typical follicles that are present in the limbar area. Don't forget the limbus is the junction between the bulbar conjunctiva and the cornea. So the follicles seen there, okay, we see the picture later, are apert follicle. The panos is infiltration of the cornea with vascularization. It may be regressive or progressive. The ulcer may sometimes develop at the avasing edge of Panus. Corneal opacity is the end point or result of trachomatous corneal lesion. Classification of trachoma. The Fisto classification was designed by WHO in 1987. This described the consequences of trachomatous inflammation, and it is divided into five: the TF, TI, TS, TT and CO. TF is trachomatous inflammation, which is which gives rise to the follicular stage. Trachomatous inflammation itself is the TI. Trachomatous scarring is TS. Trachomatous tracheasis TT, and corneal opacity is CO. So this is a pictorial representation of the various stages of classification of trachoma according to WHO. You can see the first one is the normal tarsal conjunctiva. There are no follicles on that picture. The upper eyelid is turned over, that is everted for you to see the palpebral conjunctiva. The large deep lying blood vessels that are the only thing seen there, they run vertically. But in trachomatous inflammation, which is the follicular stage, there's presence of 5 or more follicles in the upper tarsal conjunctiva. Each of these follicles measured at least 0.5 millimeter in size. The trachomatous inflammation stage, these follicles are now pronounced. There is pronounced inflammatory thickening of the upper tarsal conjunctiva that obscures more than half of the normal tarsal vessels. The trachomatous scarring, after inflammation, there is healing by fibrosis. So the presence of easily visible white lines, bands or sheets in the tarsal conjunctiva gives this out. The scarring may obscure the tarsal vessels. When it now move to the stage of tracheasis, there's at least one eyelash that rubs on the globe. This because scarring has occurred, there's entropion now of the upper eyelids, making the eyelashes to rub on the cornea. If you see only one, it's already tracheasis. Then with the continuous rubbing of the eyelashes on the cornea, there's abrasion, healing. It leads to corneal opacity. At this stage, the visual vision is obscured, and then that eventually leads to blindness. The Macala classification classified into 4 stages. The first stage is incipient trachoma, or stage of infiltration. In this stage, there's aparemia of palpebral conjunctiva, and then also there are immature follicles. The stage 2 established trachoma, or stage of fluid infiltration of mature follicle. It is also it has papillae and progressive corneal panels. Stage 3 is also the cicatrizing trachoma, or stage of scarring, while the last stage, stage 4, is heat trachoma, or stage of sequelae. This classification is according to Macala. For diagnosis of trachoma, the is made from its typical sign. Clinical diagnosis of trachoma is made from the sign, and at least 2 sets of signs are needed out of all the ones we've listed before. You have conjunctival follicles of and papillae, palmous progressive or regressive, epithelial keratitis near superior limbus, and signs of cicatrization or is sequelae. So at least two sets of signs should be present after of all this. Laboratory diagnosis are only employed for research purposes, and they include conjunctival cytology using the giemsa stained smear, detection of inclusion bodies in conjunctival smear may be possible by giemsa stain, iodine stain, or immunofluorescence staining. Then other tests that can be done, don't forget they are mainly for research purposes: pulmonary change reaction, isolation of chlamydia virus cell culture. Differentials: the epidemic keratoconjunctivitis, palpebral form of allergic conjunctivitis. The safe strategy has been used for treatment of trachoma. The S is for surgery, A antibiotics, F is for facial hygiene, and E is environmental sanitation. For surgery, indication for surgery include one or more central eyelash that is turning in while patient looks straight, evidence of corneal damage from tracheasis, severe discomfort from tracheasis. The surgery done in this case is tarsal rotation. Epilation can also be done. Indication for epilation is elderly patient, medial or lateral internal eyelash with no corneal complications. Contraindications to surgery include defective lid closure, poor general health, and children. The use of antibiotics is indicated in active cases of trachoma. The antibiotic can be given either topically or systemic. Topical is used for individual treatment. It is safe and cheap. Tetracycline or erythromycin can be used, 1% tetracycline or 1% erythromycin, given 4 times a day for 6 weeks. Then topical sulfacetamide can also be used. Continuous treatment for active trachoma should be followed by an intermittent treatment, especially in endemic or upper endemic area. For systemic therapy, tetracycline or erythromycin can be used at the dose of 250 mg orally 4 times 4 times a day for 3 to 4 weeks. Erythromycin can be given at 500 mg orally BD for 2 weeks in women of childbearing age. Doxycycline is given at 100 mg orally twice a day for 3 to 4 weeks. Then a single dose of azithromycin is the treatment of choice in trachoma. It is given as a dose of 20 mg per kg up to 1 gram. Combined topical and systemic therapy regimen can also be done. Facial hygiene, you counsel the patient on washing hands frequently after using the toilet, after touching before preparing meal, before touching the eyes. Then wash the face always, because the hands and the face they will go together. As you are washing your hand, you are washing your face. Then environmental sanitation, keeping of the environment clean, proper disposal of sewage and refuse to limit flies, to reduce flies and limit the way at which fly contaminate the um contaminate things around. How and when to treat. So treat for trachoma, you determine the district level prevalence, and assessment of the community level is also done. So you determine the district level prevalence of trachoma in 1 to 9 year old children. If this is 10% or more, there is need for mass treatment with antibiotics throughout the district. But if it's less than 10%, assessment is done at the community level in areas of no disease. The assessment at the community level is undertaken in communities in which the prevalence of trachoma is 1 to 9 year old. In 1 to 9 year old children is 10% or more. Mass treatment with antibiotics is done in this case. In the if the prevalence of 1 to 9 year old children is 5% or more, but less than 10%, then the targeted treatment should be considered. In communities in which the prevalence of trachoma is 1 to 9 children is less than 5%, antibiotic distribution is not recommended. What are the endpoints of trachoma and the ways of tackling them? We have concussion may be removed with a hypodermic needle. Trichiasis may be treated by epilation, electrolysis or cryolysis. Entropion should be corrected surgically. Xerosis, that is dry eye, should be treated by artificial tears. What is the role of family physician in trachoma care? As family physician, we should teach, educate people on good personal hygiene and environmental sanitation. Yeah, health education, how to take care of their health. How to take care, the importance of taking care of their environment and also taking care of their health. When they notice anything, they should come to the hospital. There should be regular planned antibiotic treatment in areas where trachoma is endemic. Then early diagnosis and treatment of conjunctivitis. Monitoring of vulnerable groups, children and women. Don't forget we said it's commoner in children, because these children they are the ones that play with with sands, play outside, touch dirty things, and women take care of these children. In some communities you even see children dey poo outside in open places. So women are the ones that care for these children. So we should monitor vulnerable groups, and immediately we take note of any risks or see any symptom that suggests trachoma, appropriate antibiotics should be commenced. Then timely referral help to limit disability for trachoma. When you see it's getting bad, you have to refer. You don't just keep and manage. Then for those that have already have complication, how do we reintegrate them back into the society? That is where the rehabilitation comes in. Those that are blind, how do they cope? So we have a role, and also as a family physician, where there's room for improvement. That gives rise to the research, ways in which these things can be tackled. We can go and read more and find out other things that all fill in the blanks, um spaces that need to be filled as regard trachoma. In conclusion, trachoma is a disease of great public health importance and a major cause of irreversible blindness. The safe strategy advocated by WHO is key in the prevention of the disease and in treatment and prevention of complications including blindness. Health education, especially at community level, creates awareness and will help in reducing spread and the transmission of the disease condition. These are my references. Thank you.